Hello, my name is Kristen Robinson. I'm a coder, auditor, and educator, and I'm the founder and owner of the Coding Corner Medical Coding Education. Today we are talking about sepsis, severe sepsis, and septic shock. Welcome back to Find That Code. In this video, we are talking about sepsis sequencing. We're going to walk through sepsis, severe sepsis, and septic shock, and how they tell the story correctly with your codes. If you've ever gone back and forth with a provider or an auditor on what's principal, this is for you. A couple of always true facts before we touch a code book. First, sepsis is a life-threatening organ dysfunction caused by infection. That organ dysfunction is what makes this different from a simple UTI or pneumonia. Second, documentation is king here. We don't upgrade or downgrade their words. Third, sequencing is the clinical story, the condition that prompted the admission and required the principal treatment is usually principal. Codes follow clinicians' documented diagnoses and the causal relationships they record. Always start with the alphabetic index, confirm in the tabular, and follow the official guidelines. Those guidelines are where sequencing direction lives, not by opinion. Sepsis means infection with organ dysfunction. Severe sepsis is a phrase you'll still see. Some clinicians use it and you code to documentation, but watch guideline language. Septic shock is sepsis plus persistent hypotension needing pressors. That usually changes sequencing and adds higher severity codes. If the provider documents causation, for example, sepsis due to UTI, link and sequence per the causation. If there's no causal statement, sequence by the provider's intent or query the provider. And if sepsis and the organ dysfunction show up as separate documented diagnoses, both get coded. Was sepsis the reason for admission? Did they name the infection source? Is organ dysfunction linked to that infection? And crucially, was septic shock present and were pressors used? Those answers will drive your sequence. Example 1, sepsis due to UTI, acute kidney injury. You code sepsis first, then the UTI, then the AKI. The organ dysfunction, otherwise known as the AKI, is coded separately when documented. Example 2 shows directions matter. If they admitted for pneumonia and later it progressed to sepsis, pneumonia would be the principal diagnosis. If they were admitted for sepsis from the start, sepsis leads. Timing and clinical reason for admission are everything. Septic shock tends to force sepsis to principal because it's the acute life-threatening condition requiring treatment. You'll code the sepsis, the septic shock indicator, and the source infection. Query the provider when causation isn't clear. When the principal reason for admission is fuzzy, or when organ dysfunction is suspected but not documented. Short, specific queries work best. On this slide, we're walking through a fast, reliable way to code septic shock using ICD-10-CM. Think of this as your mental checklist whenever you see documentation that hints at sepsis, severe sepsis, or shock. Number 1, start with the underlying infection. The very first step is always to identify the systemic infection. ICD-10 requires that the infection be sequenced first, never the R65 codes. In our example, the patient has sepsis due to cellulitis. So we start by coding the cellulitis itself, which is L0390. Number 2, add the sepsis code. Next, we want to assign the code for the systemic infection. If the documentation simply states sepsis without identifying the organism, we use A41.9. If the organism is specified like E. coli, staph, or strep, you would choose the more specific A41 code. Number 3, determine whether severe sepsis or septic shock is present. Septic shock is not just sepsis with low blood pressure. It is considered a form of acute organ dysfunction. Because of that, septic shock automatically meets the definition of severe sepsis. When septic shock is documented, we must assign R65.21. This code can never be the principal diagnosis. It must follow the systemic infection. Number 4, add any additional acute organ dysfunction codes. If the patient has other organ dysfunctions like acute respiratory failure, encephalopathy, or hepatic failure, those must also be coded. Remember, septic shock already implies organ dysfunction, but ICD-10 still expects you to code each specific organ failure when documented. Number 5, apply sequencing rules. The sequencing is non-negotiable. Underlying infection, sepsis code, R65.21 for septic shock, additional organ dysfunction codes. If severe sepsis or septic shock is present on admission, the infection is still the principal diagnosis. If it develops after admission, both the infection and the code become the secondary diagnosis. Number 6, quick example from this slide. In our example, the correct sequence would be A41.9 for sepsis, unspecified organism, L03.90 for cellulitis, unspecified site, and then R65.21 for the severe sepsis with septic shock. This is the clean, guideline-compliant way to capture septic shock in ICD-10-CM. Okay, guys, this completes today's session for the Coding Corner Find That Code.